Hi, everyone. Thank you so much for joining us this afternoon for another Unpacking Bedside Bioethics session. My name is Jamie Conner-Menzies. I'm a clinical ethics assistant professor at the Center for Bioethics at the University of Minnesota. Today's session is going to be presented by Joel Wu on the true role of autonomy in medicine. So let's go ahead and get started. So before we begin, I want to remind those who are in the mHealth Fairview system that the Center for Bioethics offers ethics consultation services 24/7. We have our pager number here on the screen. We're available by pager or through Epic Consult. If you have an ethics question, want to just a curbside chat or have a full-blown ethics consult, feel free to consult us. We'll be available to help you out. So today our speaker is Joel Wu. He is clinical ethics assistant professor at the Center for Bioethics, as well as a senior lecturer in the Division of Health Policy and Management at the University of Minnesota's School of Public Health. Joel Wu is a clinical ethics consultant for the mHealth Fairview system. We're excited to have him today to talk about autonomy and get into this discussion and this topic a little bit more. And Joel, no financial information.
I have no disclosures.
Great. And some housekeeping rules as we get started. So in this webinar, please use the Q&A function for any questions that you have and reserve the chat for technical issues and things like that. We will go through and have a Q&A session at the end. Looking forward to that aspect of this today. So again, use the Q&A. If you want a certificate of attendance for continuing education credits, you can request that through this email here. You have to attend at least 75% of this talk to receive that certificate. If you're pursuing IPE credit, so if you're a University of Minnesota student who's actively involved in allied health, dentistry, medicine, nursing, pharmacy, other things, if you want IPE credit, stay after this event. We will have a 15-minute discussion to talk about the interprofessional aspects. Again, that's only for University of Minnesota students. All right, and now let's get into our lecture. So I will hand it over to you, Joel.
Great, thanks, Jamie. So I want to start this with a preface and sort of a limitation. I want to start by emphasizing that this is a limited and practice-focused discussion. This is not about broader societal kinds of autonomy with the tensions that arise between individual citizens and with other institutions in our community or population-level interests. This is narrowly about patients and clinicians and the rights and obligations that arise between them in the context of a care relationship, with an emphasis on the care relationship in a hospital setting. And my goal here is to be practical. I'll be presenting some additional theoretical information and history, but just to try and provide some context to make better sense of where I hope my practical advice comes from. Okay. This is the roadmap. I want to start by describing controversies about patient autonomy, and then to specifically address problems with what some people have called the triumph of autonomy, particularly in the context of medicine in our society. Next, I'd like to try and approach defining and contextualizing what we mean by patient autonomy, and then share a practical framework after which hopefully I can demonstrate the framework in application to cases. So, describing controversies about patient autonomy, I suspect that clinicians have encountered assertions by patients about their autonomy, and that patients have asserted the idea to clinicians with a kind of expectation about what it would require of clinicians and the care that they receive. Different patients will enter into a care setting and care relationships with different conceptions of what patient autonomy means, what rights they hold, and what obligations or duties we have to them as care providers. And usually patients don't think about their duties to us, all right, or their duties as participants in their own healthcare. It's my impression that there has been an increasing number of conflicts regarding patient autonomy, and it's based on an expanding scope of what patients believe their rights to be. I think this is informed in part by public discourse about patient autonomy, and in particular, I think two recent issues in our society have really highlighted it. And that's abortion and COVID. So about abortion, this is outside of scope, but I want to bring it up because it does implicate our conceptions of autonomy and community discourse. This OBGYN doc said, the issue of the criminalization of abortion has resulted in the loss of patient autonomy for a particular treatment, right? About COVID, which is the other really significant issue, there have been a lot of claims regarding individual and patient autonomy having to do with things like mask and vaccine mandates, which are more about the autonomy and liberty within a societal context. The issue of treatment specifically with things like ivermectin or hydroxychloroquine are closer to what we're talking about. But the discourse is interesting, right? And so we have folks like Aaron Rodgers taking a position on it, where he says, I believe strongly in bodily autonomy and the ability to make choices for your body. In addition, not to have to acquiesce to some woke culture or crazed group of individuals, which is an interesting sort of indictment. Recently, there was an effort in Texas for lawmakers to pass a bill that would allow employees to sue their employers for COVID vaccine mandates. One of the legislators that was a sponsor and co-author of the bill said this about patient autonomy. That is the idea that a patient of sound mind and body has a right to accept or refuse medical advice and treatment, regardless of what medical expertise has to say on the matter, which is an interesting position also. And finally, there was a case in Ohio, and this is approaching the specific area of our discussion today, right, which is hospital treatment. There was a case where a family secured a prescription for ivermectin, and they demanded that the patient receive this treatment and went to court over it. There was an emergency order that essentially compelled the hospital to provide it, and it was appealed. And the appeal, the judge overturned the earlier order, saying, while the court is sympathetic to the plaintiff and understands the idea of wanting to do anything to help her loved one, public policy should not and does not support allowing a physician to try any type of treatment on human beings. So this is articulating a view that there might actually be some limits as to what treatment can or should be given, right? So this gets us to our first illustrative case, just to sort of set up our conversation. You have a COVID patient with respiratory failure in the ICU, and they demand treatment with ivermectin. Patient has decision-making capacity. Patient and the family have secured a prescription from a physician who does not have hospital privileges, and the patient is otherwise receiving appropriate care consistent with the prevailing standards. Should the care team treat the patient with ivermectin? What do you guys think? I'll give you a few of the maybe 10, 20 seconds or so to respond here. Wait for the numbers to start or to stop tallying. Try to get everybody in. Looks like that's slowing down. What I'm seeing is 89% of you are saying no, we should not treat the patient with ivermectin. 11%, 17 out of 160 looks like saying that we should have treated with ivermectin. Okay. So let's think through this a little bit. So there's a conflict, right? And broadly, I would say the conflict here is between respecting the patient's demand for a particular intervention. And what I really want to emphasize here is that this is a demand, not a refusal. This is an important distinction that we're going to develop more later. The second thing, the second thing is that it's pretty well established that ivermectin does not improve COVID outcomes for similarly positioned patients. So there's a conflict in between acceding to the patient's demand for ineffective intervention, as well as potential duties not just to not cause harm, but also only to act in ways that advance the patient's welfare. The second issue that I think is really important to think about when we think through these conflicts isn't just the nature of the conflict, but what might be behind the conflict, which is to say, is there anything that's impairing this patient's autonomy? And is this a barrier or an impairment that can be resolved? So is there a good faith misunderstanding about ivermectin? And is this a problem that could be resolved with the provision and the articulation effectively of the information that we have? In some cases, certain barriers might be lack of capacity, but if it's information, then we have to do something about it. And this is a detail that we'll develop a little bit more shortly. I would maintain that it is ethically justifiable to refuse to treat this patient with ivermectin, and that there may actually be an ethical duty to not treat with ivermectin. And the basis of my reasoning here would be to say that there is no positive right for patients to receive ineffective, harmful, or illegal interventions, and that there is no correlated obligation on clinicians to perform them. Furthermore, there is an obligation on clinicians to not cause harm to patients. And in addition, the absence of harm alone is insufficient to justify ineffective treatment. Because there's also a duty to act in ways that advance welfare, and also commitments to professionalism and the preservation of the institutions that allow for complex delivery of care. That's outside of scope. So let's focus more today on the conflict between the individuals and the clinicians. So the question that I want to sort of frame the rest of our talk with is, if we don't permit the use of ivermectin, did we violate obligations to respect this patient's autonomy? And if we did, was it wrong? And the answer might depend on what we mean by autonomy, and also whether there are other competing obligations that might be more important. It might actually be that in a narrow sense, we failed to respect the patient's autonomy, but at the same time that there are competing obligations that limit or supersede that patient's choice, right? So I think there might be a couple of positions to sort of explain here that would be the boundaries of our conversation, the boundaries of the views of what autonomy is and what patient autonomy is. I think there might be two competing views here. One that's more represented by, for example, the legislator from Texas and Aaron Rodgers, and the other view that's more represented by the judge in Ohio. Position one would be that patients have a right to choose any treatment they want, and that we should not interfere with the patient's choice. And position two would be that there are limits on what patients can choose, and that patient interests are not reducible to their choices, that there might be other obligations to the patients that may be more important than choice alone. Position one means that we should have treated the patient with ivermectin because it respects their autonomy, and that our refusal to treat is an interference of their choice, and that we would be using our power to withhold the treatment that they want. Whereas position two means that patient autonomy has limits, and that professionals have competing obligations, including to only provide treatments that benefit and don't cause harm. The problem with position one might be that this may result in professionals using their professional skill and power and position in community to cause harm, both at the individual and at the community level. And the problem with position two is that we're worried about paternalism, right? And this is the problem of professionals using their power in ways to treat patients in ways that are inconsistent with their goals and values, and in particular, involuntary treatment. Concerns about paternalism have a long history, right? And they've resulted in a loss of trust in professionals. If it's resulted in a loss of trust in authorities, and an increase in access to knowledge has led to the idea of things like the democratization of professions and the democratization of medicine and the empowerment of patients. So I think autonomy has expanded. and patient autonomy has increased in power and scope relative to other values. Some folks have called this the triumph of autonomy, both in good and bad ways. So what do we mean by the triumph of autonomy, and are there problems that are associated with the triumph of autonomy in our society? This gets to our second poll. I'm really actually curious to get the take of this group of folks. So, has the duty to respect for patient autonomy become imbalanced in American healthcare? What do you guys think? See, we got 73% of participants responding. I think we can probably call it. I think it's interesting. It's a tough question, and a lot of it, I think, has to do with what our conceptions of autonomy are, right? 70% think that the duty to respect for patient autonomy has become imbalanced. 30% would say no. So a lot of bioethicists have obviously some opinions about this. And there's a pretty strong thread, even from people that were the original sort of contributors to the idea of respect for autonomy as a principle, have taken positions on it. Daniel Callahan, who used to be the director of the Hastings Center, said, "Nothing has exasperated me so much as the deference given in bioethics to the principle of autonomy." Similarly, in writing about the notion of the triumph of autonomy in American bioethics, Paul Wolpe wrote, "For better or for worse, autonomy has emerged as the most powerful principle in American bioethics, the basis of much theory and regulation, and has become the default principle. Indisputably, patient autonomy has become the most powerful principle in ethical decision-making in American medicine." And what's particularly interesting, I think, is that Beecham and Childress, who are the guys that originally developed and articulated principlism in their book, The Principles of Biomedical Ethics, have addressed this in a number of ways. In their fourth edition, they said, whether respect for the autonomy of patients should have priority over other professional obligations like professional beneficence has become a central problem in biomedical ethics. Autonomy rights have become so influential that it is difficult to find clear affirmations of traditional models of medical beneficence. So a lot of smart people, and arguably some of the scholars the most responsible for this, think that the emphasis on respect for autonomy has become to some extent problematic, and that the meaning and scope relative to other commitments may have become imbalanced. Bishop and Childress have tried to preempt this, and they've tried to limit it, I think. And they say, a misguided criticism of our account is that the principle of respect for autonomy overrides all other moral considerations. This we firmly deny. They go on to explain, neither the patient nor the physician has premier or overriding authority. And no preeminent principle exists in biomedical ethics. And they go on to explain that this position is consistent with their earlier claim that beneficence provides the primary goal and rationale of medicine and healthcare, whereas respect for autonomy, along with non-maleficence and justice, sets the moral limits on the professional's actions in the pursuit of this good or this goal. This is as close to the answer to what the true role of autonomy is, and at least from a principlist standpoint, and at least in trying to follow up with the title of this talk. I'm not exactly a rigid principlist here, but I think it's a really valuable, and I mean, it's well accepted that it's one of the most influential frameworks that we have. But I think you could make the argument that principlism contributed to this problem, And even if the authors of Principalism think it's a problem, it's enough of a problem that the authors think that they should need to have to clarify that it should never have been a problem in the first place, which is to say that the four principles have a relationship with each other and they have equal weight, right? Beyond that, even within the principles framework, what they're really emphasizing here is that respect for autonomy has to be relative to something else. According to the authors, the primary purpose of medicine is doing good, right? And that the guardrails are autonomy. The guardrails are doing harm, but the primary goal is beneficence. So how did we get here? It's really important to provide some context because I don't think it's without reason. And we don't need to go into the details here because you are all, I think, familiar with this, but a lot of the reason why we're here is as a strong reaction to paternalism and terrible things. So strong commitments to respect for patient autonomy was a solution to these intrusions and violations in a pattern in history of really egregious violations and intrusions of individual interests, rights, and autonomy. So what do we mean by patient autonomy, right? Because this is something that I think it's really critical to have some common ground about before we move on with how we actually practice with the obligations to respect patient autonomy. So I'm a little, it makes me laugh a little bit because every other or most of the philosophical literature addressing autonomy start with this, but I'm going to start with it too. Which is to say the original idea of autonomy isn't about individuals, it's about city-states and societies. This is a Greek word. It's autonomia, which means it's the self-rule of a Greek city-states. This isn't about individuals, and it's about the self-rule of a society as opposed to colonial rule, where the affairs of your society are governed by another state or another society elsewhere, outside and separate, right? But this has been applied to individuals. So as applied to individuals, there are some really important features to parse out and to be specific about when we talk about what our obligations to autonomy might mean. So the first thing to emphasize here is that when we're talking about autonomy as applied to individuals, it is a feature or a capacity of individual persons. And as a capacity of individual persons, it's relational, it's selective, and it's graduated. So when we say relational, we mean that it has to be a freedom from something. Autonomy isn't really a very coherent concept if you live alone on a desert island, because there isn't another person or other institutions to constrain your freedom or your liberties. It's freedom from something else. It's freedom from someone else constraining what you want to do or what you believe the right thing for you to do is. We'll talk more about liberty soon. The next feature is that it is selective. People can be autonomous in some matters about their life and not in others. So one of the examples that I'll give to illustrate this is about, for example, a patient with an eating disorder like anorexia, but also with another independent diagnosis like a cancer or something. This particular patient may not be able to make autonomous decisions regarding food and drink because of the underlying psychiatric eating disorder condition, right? But they might be able to make decisions regarding their cancer, right? The last feature worth noting here is that it's also graduated, which is to say there may be varying degrees. Kids have different degrees of autonomy than adults. And as kids get older, and in some cases as adults age, with also varying degrees of other kinds of mental, emotional, behavioral conditions, there can be waxing and waning and increasing degrees or decreasing degrees of the capacity, right? So autonomy is relational, selective, and graduated. Beyond capacity, there also needs to be freedom. So this is to get into more detail about the difference in between the context of the person and the person themselves. So this is from Bishop and Childress as well, which is to say, to be autonomous, a patient should have two things. The first is agency, which is the capacity for intentional action. The other is liberty, which is freedom from constraints, influences, and barriers. We'll talk about our obligations to both shortly, but it's really important to think about the idea that we require both agency, a capacity of the individual, and also freedom from constraints. You need both for a patient autonomy, okay? So there's different competing definitions here, or a range of potential definitions. The more minimalist construction here is merely a right to act without interference from others. And that as clinicians, we've met our duty to the patient as long as we don't interfere with their choice. And you can have more holistic definitions, and these are from authors that I'll quote. A lot of my talk is informed by the work of Edmund Pellegrino, and I like his proposal here, which is to say that autonomy is the capacity for self-rule that is a quality inherent in rational beings that enables them to make reasoned choices and to take actions based on a personal assessment of future possibilities weighed in terms of their own value systems. Another definition in the Routledge Encyclopedia of Philosophy is the capacity to assess critically one's basic desires and values, and then to act on those that one endorses on reflection. So there's an emphasis on capacity, there's an emphasis on reflection and knowledge, and there's also an emphasis on the ability to act based on those. Another sort of analogy to sort of distinguish some of the impairments or the incompleteness of autonomy would be another example of an eating disorder patient who refuses hydration and nutrition. So if they were refusing food or nutrition, but they wanted to live and to get better, it might be that they're not able to act based on their set of goals and desires, right? Their goals and their desires and their values are to live and to participate in life, but their actions would result in the opposite. So there's an impairment in the patient's autonomy. Another important distinction to make here is about the word capacity in this context. And it's really important to distinguish this word that we're using, capacity, from the specific idea of decision-making capacity, which is what Jamie talked about in the last episode of Bedside Bioethics. In the preceding definitions, the authors, when they say capacity, they're talking generally about a person's ability or power to do something. They're not talking about this narrow technical construction of decision-making capacity that Jamie described. But there is a really, really important relationship. So the relationship is that decision-making capacity is a necessary condition for autonomy, right? But the decision-making capacity is in and of itself not sufficient. Autonomy also requires liberty. So there may be obligations to also support their autonomy by providing information, removing coercion and deception, or empowering the patient. A person with decision-making capacity but lacking appropriate information or power doesn't have autonomy. And so to think about when we think about when and how we have obligations to either respect autonomy or potentially to overrule it in following other obligations or commitments. So there are really important implications here, right? Because the implications follow from what we understand autonomy to mean and the obligations that follow from it. Simply honoring patient choice might result in harm to the patients themselves and others in community and the care team members. But overruling patient choice is always concerning and can be done the wrong way, even if it's justifiable. So all that to say, our duty to the patient's interests might include more than just respecting narrowly their choice, right? This is an interesting distinction that's been written about by a number of other authors, and I think sort of crystallizes some of the tension in the discourse and some of the language. But I'm curious what this group thinks. Is there a difference between respect for persons and respect for autonomy? Give it a few more seconds. Looks like it's slowing down. This one's a lot more, there's a lot more consensus on this one. %, participated. Looks like 93% of the present participants think that there is a difference between respect for persons and respect for autonomy. I agree. Which is to say, I think a person is more than their autonomy, and their interests aren't reducible to their choice. I like what Pellegrino has to say, because he contrasts autonomy with the integrity of the person. He says that autonomy is a capacity inherent in a rational person, but it's something that it's possessed. It can be lost, it can be transferred. So some people never really have it, and it can exist in varying degrees. As we said earlier, it's graduated. Pellegrino, in contrast, says integrity is a matter of being. It's an attribute possessed by all humans, competent or not, adult or not, conscious or not, and it does not admit degrees, right? So there's some sort of fundamental value and interest in the integrity of a person or a person's interests. So it's that a person's interest isn't reducible to their ability to choose or their choice. And in some cases, we can act to advance a person's interests while constraining their choices. And if that's the case, we also need to have some values that guide us when people have impaired or incomplete autonomy, so that if we find ourselves in a position where we need to act for a patient that has impaired or incomplete autonomy, we have values that can guide us on how to act. So how do we balance and respect for autonomy in practice? This is particularly when we have patients with impaired or incomplete autonomy who can be harmed if we simply honor their choice. And we have the problem of patients with intact autonomy that can also be harmed if we honor their choices. And patients with intact autonomy that can also make choices that harm others in community. So onto this practical framework that I'd like to propose. This is not meant to be comprehensive. This is meant to provide some guidance about how to resolve some more straightforward issues, and then also to provide some guidance about when it might be helpful to contact the ethics consult service. Okay. So some important distinctions that inform the framework that I really want to clarify first. I want to start with a distinction between negative and positive rights. So a negative right is a right to a refusal, and it's a right to non-interference. In a clinical context, that means there's a correlated obligation on clinicians not to involuntarily treat patients. It's a negative right. In contrast is the notion of a positive right, which is a right to receive certain goods or services from others, and meaning that there is a correlated obligation on, in this context, clinicians to actively provide a treatment or an intervention. When we were talking about the ivermectin case, that was concerning a positive right and a positive claim, not a negative one. This is not a refusal of an otherwise medically indicated treatment. It was a demand for another clinician to provide in a hospital context potentially ineffective intervention. Okay, positive rights, negative rights. Another important distinction. So the second thing we need to address is the potential causes for incomplete or impaired autonomy. So we can ascertain whether or not there are duties on clinicians to resolve them if possible. And I think it's worth drawing a distinction between internal constraints on autonomy as opposed to external constraints on autonomy. An internal constraint is a character of the patient that is a barrier to their autonomy. Some may be resolvable, some might not. So pediatric patients, children and infants, they don't have complete autonomy, and they actually have very little autonomy. And given the circumstances, it will not be a resolvable internal constraint. In contrast, there may be patients who are having a psychiatric crisis or may have other neurologic conditions that result in barriers to their autonomy. And it's a lack of decision-making capacity and impaired autonomy. These might be resolvable. If it's just a patient who's been off their psych meds for a while, it might be that if you get them back on their meds, they're going to be autonomous after they're stabilized. It's the same with a neurologic condition. It might be the same with an encephalopathy, right? So it's important to distinguish whether or not it's a resolvable constraint and the differences between internal and external constraints. External constraints, in contrast, are circumstances outside the patient that are a barrier to their autonomy. This can include a lack of information. This is squarely what informed consent is trying to deal with. Patients cannot be autonomous if they don't have relevant information. Other external constraints include different kinds of coercion and deception and power disparities. This could be anything from a language barrier, where we need to resolve it with an interpreter or translator, to broader systemic societal problems. These are more complicated, but it's to say that there might be external constraints like information or lack of power that also can and should be addressed by clinicians before we think about doing anything that may be an intrusion or a restraint on a patient's autonomy. Okay, so onto the frame. You have a patient that asks for something the care teams believes is inappropriate. The first step is to clarify the conflict. So specifically, is the conflict between honoring the patient's choice as opposed to obligations to advance the patient's welfare and obligations not to cause harm? Or is it a justice concern or a fairness concern that has to do with, for example, the allocation of scarce resources? If it's a justice or a fairness question, consult ethics. But if it's about the tension between honoring patient choice and avoiding harms to the patient, then it's important to distinguish the positive, negative, right question. Right? So is this patient refusing something potentially beneficial, or are they demanding something harmful or ineffective to be done? The second step is to identify and resolve any of the barriers or constraints to the patient's autonomy. So is there a reason or a cause that may be underlying or informing this particularly concerning or inappropriate choice we think? So is this an internal barrier? Is this a psychiatric condition that we can address with medication? Is this something that can be otherwise resolved with medical management? Or is this an external barrier? So a lack of information or a language barrier, or if there's the presence of some sort of coercion that we can resolve. Identify any barriers and seek to resolve those barriers. If you can resolve those barriers, it changes the obligations we have to the patient, right? If you have some idea about the patient's autonomy and whether or not the barriers have been resolved, if the constraints to the patient's autonomy have been resolved and you have a patient with intact autonomy, it's important that we honor the refusals of a patient with decision-making capacity and intact autonomy. There's an absolute right for a patient with intact autonomy to refuse unwanted treatment that's inconsistent with their goals and values. This is the negative right. This is the right to refusal and the right to non-interference. In contrast, with a patient that does have intact autonomy, if they're requesting something that's clearly ineffective, illegal, or harmful, there is no obligation on clinicians to participate or to be compelled to provide ineffective, illegal, or harmful interventions. This is the positive right problem. Okay. For any other questions about the relative burdens and risks, this is when you should consult ethics, because then we can try to apply some common frameworks to resolve this in a more transparent way. So this is for patients who have intact autonomy and that the barriers and constraints have been resolved. If the constraints and the barriers to patient autonomy cannot be resolved, and so the patient still has impaired or incomplete autonomy, there are a couple routes. And so the first is specifically for patients lacking decision-making capacity. If they had decision-making capacity and autonomy prior to their current condition, it's important that we do as much as we can to affirm what their values would have been in the present. And so the tools to do that are to honor known values and choices, to identify an appropriate surrogate that can effectively fulfill the substituted judgment standard. And in the absence of any knowledge about what the patient would have wanted, then we have to resort to a best interest standard. Okay. For other questions, again, consult ethics. Regarding emergencies, absent a well-documented and known refusal, it's also always important to treat medical emergencies. So I've tried to put it all together here. The really important things to emphasize here are that before any actions are taken that may be inconsistent with a patient's interests and their autonomy, you have to do your best to try to remove impairments and constraints on their autonomy. So these are the internal and the external barriers. The range of options for what we do with someone who has impaired or incomplete or autonomy is very different than what we can do for someone who is not impaired. The path of honoring refusals of someone with complete or whole autonomy is really, really important to emphasize here. So that's the green path. This is essentially to honor the biggest problem in paternalism, which is involuntary treatment that's inconsistent with the patient's goals and values. If a patient has intact or unimpaired autonomy, we have to honor their refusals. The path that's following patients who have unfixable barriers and impaired or incomplete autonomy is to resolve the problem that their choices might result in their own harm, right? But that's only for patients where it's relatively clear or well understood that they have impaired or incomplete autonomy that we can't resolve. And that opens up the pathway for us to use other tools to advance their interests, even though it may not be consistent with their choice. Okay, so let's apply to a few cases, and then let's get into the Q&A. Case 2. A 13-year-old patient is refusing chemotherapy for a curable cancer. The patient has age-appropriate decision-making capacity, and the parents in this case are deferring to the patient's choice. They're not refusing on their own. Okay. This is getting into some detail that I don't know this in scope, but it's not that the parents here are saying that they're opposed to it on behalf of their kid. They're just deferring to their kid's preference. Is it ethically justifiable to involuntarily treat this pediatric patient for cancer? Give it a few more minutes. Okay. This is almost 50-50, which is interesting. 51% say yes, 49% say no. I would argue that it is ethically justifiable to treat the patient here. The patient is refusing medically indicated treatment, and since the patient's 13 years old, the patient has incomplete autonomy. There wouldn't be any barriers to the extent that there's clear communication and support. The internal constraint that we have here is just of the patient's age and development. With pediatric patients, parental authority is a different issue, which is to say that we rely on parents to make choices on behalf of their kids on the assumption that they know what's best for their kids and they're the best position to know what's best for their kids, in addition to the idea that they have an intrinsic interest and right to raise their families that the way they see best, right? Broadly speaking, the only time that parental authority and rights to make decisions for their kids are overruled is in following the harm principle, right? Not the best interest standard. In this case, the parents aren't necessarily refusing. It's just that they're relying on the kid. What I would argue here is that the burdens and risks of honoring the patient's choice in non-treatment are greater than the burden and risk of involuntary treatment. And so, given the condition of incomplete autonomy of the 13-year-old, that it would be ethically justifiable to proceed with treatment, even though it's involuntary, because the cure of the cancer and the opportunity for what we might, in the ethics literature, they call it the opportunity for an open future, which is survival into an open future in life, is a benefit that is greater than the burden of the involuntary treatment. Okay, let's do another case, and then we can jump to the Q&A. Okay, so a heart transplant candidate refuses to quit smoking and demands to be listed for transplant. The patient has advanced heart failure and is not a candidate for any other advanced heart failure interventions. They have been informed regarding the requirement to stop smoking and has been given resources to support smoking cessation. The patient has expressed a desire to continue to smoke and also demands to be listed for a heart. He thinks it's his right to be able to smoke and get a heart. Would it be ethically justifiable to grant the patient an exception and put him on the waiting list for a heart? This one's a lot more, there's a lot more consensus. I am seeing 92% saying that it would not be ethically justifiable to grant the exception list, and 8% saying yes. So in following sort of the analysis that I would have proposed from the framework, the conflict here is between the patient pursuing a positive right? Which is to say to want to be listed for a heart transplant and to get that heart transplant. So it's a medically indicated treatment, but in direct conflict with absolute contraindications, right? The patient has complete autonomy. There aren't any information barriers and there aren't any internal or psychiatric impairments. The justification here would be to say that the risks and burdens outweigh the benefits. A transplant is not a trivial intervention, and it doesn't stop after the surgical operation, right? This is going to be a changed life and a lifelong requirement for extensive participation and devotion to the things that are required for good outcomes and survival. Smoking is part of that. So it's not just that smoking and continuing to smoke would be something that predicts for worse outcomes. It's also the problem that the exception would be inconsistent with the fair allocation of scarce resources here, right? So I would defend the idea of not listing this patient for transplant. Let's do this one and then let's jump, because this is one that comes up a lot, and I have a little bit of extra data to sort of share, which I think is interesting. And then let's do the Q&A. So you have a patient's family that demands resuscitation for a patient with terminal cancer and multi-system organ failure. There are no therapeutic treatment options. They're in the ICU, trach vent, renal replacement therapy. The medical consensus is that the condition is not survivable. The patient currently does not have decision-making capacity. The prior advanced care planning documents designate spouse and adult children as decision makers, and the family, in following, the in-depth conversations we have with families, the family has refused advice to change the patient's code status to DNR, and explicitly demand resuscitation attempts and claim that anything less is giving up and would be the same as murder, right? So when the patient arrests, would it be ethically justifiable to withhold CPR, even with the full code status? Yeah, this is closer to 50-50. This is really hard. In developing this talk, my conversations with other ethicists was also pretty conflicted. It's almost 50-50. 49% say that it would be ethically justifiable to withhold CPR. 51% say no. So I would argue that it would be ethically justifiable to not initiate resuscitation. Because the patient's family is demanding treatment that may not be medically indicated. So there's a general obligation to affirm the patient goals and values as represented by appropriate surrogates. Which to say, it works in one direction, but not necessarily in the other. Patient-directed DNRs should be honored because they're the negative right. They're refusals of a potentially appropriate medical treatment. However, the refusal to consent to a change in code status and the refusal to consent to DNR does not necessarily create a positive right and a correlated duty to treatment that is not medically indicated, including CPR. This is particularly on the background and the history of things like show codes and slow codes, which I would also argue are ethically problematic. The position that I would defend is that the decision to initiate and the duration of CPR are medical decisions. And it is ethical to withhold or stop CPR in following medical judgment. This comes up a lot. And there's some data. The main thing that I want to share with you is we hear about this a lot, and we have 13 consults so far this year specifically about it in our system. Okay. Here are the main points. Then let's go to Q&A. I'm sorry, I'm a little long. The main points are this. Autonomy involves both non-interference by clinicians and the presence of patient capacity. There is an ethical obligation to resolve the fixable barriers or constraints, and that patients with intact autonomy have a right to refuse unwanted treatment. However, patients cannot compel clinicians to provide clearly ineffective, illegal, or harmful treatment. Finally, patients with impaired or incomplete autonomy should be treated according to what we know of their values and also in following a best interest standard. When in doubt, call ethics. And the framework in a nutshell, when you run into these problems, clarify if the patient is refusing something or demanding something. Identify and attempt to resolve any of the barriers to their autonomy, either internal or external. And for patients with unimpaired autonomy, honor their refusals or refuse clearly ineffective, illegal, or harmful treatments. And for patients with incomplete or impaired autonomy, treat them according to, in order, their known values, substituted judgment, and best interest. For everything else, we're here to support. So I'm sorry, I only left 5 minutes for Q&A, but let's get into it.
Thank you so much, Joel. What a great presentation. We have a lot of great questions. So the first question that has come up a couple of times is about the placebo effect. Specifically, if there are treatments that might be ineffective, would the placebo effect justify us in administering that to a patient if they request it?
So the trouble with the placebo effect is that there's no causality that we can establish, right? And so when we have a placebo effect, the broader problem is having to do with the participation in, I think, a kind of deception, and also a participation in a kind of intervention to which we have no meaningful understanding of the relationship, of the intervention, and what our hoped outcomes are. So it's not just that we don't have any idea whether or not what we're doing is helping in any way, because that's not something that can be established. It's also that it might be participating in a community level kind of deception. And that I also think that that kind of deception and that kind of acceding to patient requests actually undermines the broader credibility of the entire biomedical and healthcare enterprise. Which is to say that patients need to rely at the community level, the belief that the only treatments that they're going to get are the ones that all of us that are participants in the biomedical enterprise have well-established evidence and transparent understandings of the mechanisms and the probabilities for why we do what we do. I hope that makes sense.
Thanks. Another question that came up a couple of times in the chat is about legal perspective and following patient autonomy. So often clinicians will honor patient's choice out of fear for being sued. What do you think about that? How do we understand this understanding of autonomy from an ethical perspective in regards to the legal culture around medical malpractice and lawsuits?
Ooh, so I'm in danger of stepping out of my lane, because even though I have training and I went to law school and stuff, I really got to stay in my ethics lane. What's legal and what's ethical are different. But what I will say is that in regards to what's ethical, it's important to think about the circumstances when the right thing may not be the legal thing and whether or not we're willing to do it. What I will emphasize here is some really interesting recent literature, post-Dobbs, about the notion of civil disobedience, where you might have a patient who has a complication of pregnancy that might result in a threat to the mother's life, and whether or not this is a matter of civil disobedience. All that, it's an extreme example to illustrate that there's a difference in between the ethical obligations and the legal obligations. Regarding liability, I gotta say, you gotta consult your lawyers, and then they can tell you what the standard of care is. And if you're within the standard of care, that you'll be in a position to defend yourself. The other thing that I will say that's not legal advice is there's a big difference in between the threat of litigation as opposed to the threat of liability. We can't stop you from getting sued. There's frivolous lawsuits that happen. That's a threat of litigation. That's not something I think we have much influence over. What we have control over is the risk of liability. So you might get sued, and it's gonna suck, but you can reduce and almost completely minimize any liability, but we can't necessarily minimize the risk of litigation.
Thank you. What a great answer. So let's talk about a little bit of the cases and some of the questions that come up from the cases. So this person asks, in your case studies, you talk about risk-benefit trade-offs. However, isn't part of patient autonomy that they decide their own risk-benefit ratio?
Yeah, certainly. Within the boundaries of what's understood to be medically possible, or what's unrealistic, right? And so there are contributions from professional expertise and judgment. What we really need to be able to do is we need to be able to figure out how the interventions that we may offer can effectively advance the underlying goals and values of a patient. And so what I'll illustrate the distinction of is the problem of, for example, selective refusals of certain medications. And so this is, for example, the problem of a patient with potentially like a drug-resistant infection that requires, aggressive IV antibiotic treatment. But they're selectively refusing certain antibiotics, right? So even though their goals and values are to be treated for the infection, they might be selectively refusing certain antibiotics. Another version of this that we have is psychiatric patients whose surrogates selectively refuse psychiatric meds. So even though we're doing something that might be inconsistent with their choice and autonomy in a narrow sense, if we treat them with what's therapeutically effective, that would actually be advancing their interests and their goals and values, even though narrowly it would be inconsistent with what they're choosing. And so to the extent that we're able to align the intervention with their goals and values, it's consistent with their construction of the benefits and risks and burdens. But if their conception of the risks and burdens, for example, of one antibiotic as opposed to another, that's something that I think we have to be able to meaningfully address.
All right, we'll do one final question. We recognize that it's 1:15, which is the official end of our section. So if you need to leave, feel free to do so. But I want to get one more question. I think this is a really great question. So this question comes from an attendee. If the patient asks the physician what choice you would make if it is your family member, if the physician gives a choice preference, is that considered paternalism? Does this mean we have interfered with the patient's autonomy? And if harm occurs from that choice, will the physician be held responsible?
I don't have a good answer for this. I will be completely transparent with you. One of the cases that I was actually thinking about proposing to the group was exactly this situation, except pediatrics, where they say, doctor, what would you do if this is your kid? Eminent, very influential ethicists have taken positions on both sides to say that it's categorically inappropriate. And there's others say that this is actually a meaningful role of the caregiving and trust building professional, right? That it actually would be an appropriate expression of a trustworthy relationship of a skilled expert. So I don't have a good answer for that one. I mean, I can direct you to the literature, but there's a lot.
Yeah, we could have a whole session just devoted to that one. All right, thank you so much, Joel, for this talk. We really appreciate your insight and your expertise. Thank you all for attending. We have further sessions for the Unpacking Bedside Bioethics series coming up, one in November and one in January. You can get access to the recording through our website, and I believe that information should be included in the chat and also might come out as a follow-up email. If you're here for IPE credit for UMN students, please stick around for a case discussion. And we really appreciate you joining us today. Thank you.